today mainly focus what our country has achieved and what is the happy Independence Day to everyone. And we owe this independence not only to ourselves, but every citizen of our country. So welcome, Dr. Sharda Jain, Dr. Nirja. Perhaps she's not there, Dr. Shweta, Dr. Shankar Narayan, and Dr. Ajay Aurora. And we will straight away go to the discussion that with the high magnitude of CA cervix, what is the magnitude in your perspective and in your clinical practice? And when the WHO appeals emphatically to all country, vaccinate 90%, screen 70%, and treat 90%, then and there. Dr. Sharda, Madam, what is your perspective that where we have reached with your great experience in not only the advocacy, but in realistic teaching terms to all gynecologists?
Thank you, Dr. Sadhna. I think today is the great day, and it will become a memorable day because both gynecologists and pediatricians are got together. And this is on the motivation of Dr. Arora that, this particular meeting has been called today, because it is time that the experts like Dr. Shankar Narayan, Dr. Batla, Dr. Partho, who have done tremendous work on this particular area, they have to say for adolescents whether single dose of our indigenous vaccine is okay. It should not happen like COVID, we had a vaccine and we said we could not compare for the Western world. Time had definitely said that. But I think, as for the cancer cervix was concerned, cervical cancer Mukt Bharat was a dream, but now it has come to a stage where it can be a reality. And what we have to do is, thanks to the call by the WHO on the 17th of November 2020 of this 90-70-90 three pillars, I think things look doable. And now with the SAGE recommendation, first it came out that, single dose of vaccine, because they found that 12% people in 150 countries where the national immunization program was going on, only 12% got the second dose. So with this when the 12% second dose has been given in those countries where the national immunization program is going on, the debate came whether one dose is good enough. So Dr. Batla, I'm unfortunate that Dr. Batla is not here. Dr. Batla has been involved from the very beginning. And we have experts like Dr. Shankar Narayan. I've heard him earlier, and he is very clear that, single dose will probably make wonders. So what is the aim? Today, India stands at 18 per lakh as far as cancer cervix is concerned. What is our aim? 4. Long way to go. But I think, with everything available with us, if we ensure that a 90% of adolescent gets the vaccination, and here I will plead not only for the girls, but I think I will plead on a private sector, even the boys should be given a vaccination. We should enforce that the screening should be done at 35 and 45 according to WHO, because it is seen that the brunt of the cervical cancer is not seen earlier than 30 years so much. So there is no point screening earlier than 30 years. We should screen them twice, but we should screen them with something very good like HPV screening test. But that looks to be not a reality in future. Abhi 1-1.5 saal lagega till the time the government brings that kind of a tool, because at this time, to get expensive investigation areas, it is not possible. We have to only do VIA Willi, and I call Dr. Shankar Narayan as a father for VIA and Willi, which has shown the world that it can be equally effective like pap smear. So I think, gynecologists are not tuned to VIA and Willi. They have to love VIA and Willi, because this is going to be the game changer. And I feel with one dose today is the thing is that if Dr. Shankar Narayan, Dr. Batlas, I have heard the story. Dr. Shankar Narayan also heard it. But today he has to emphatically say one dose of Cervavac indigenous vaccine is good enough as far as the adolescent girls are concerned. I think I want to hear also for boys also, because it's a gender neutral vaccine. Can the boys also be given who are less than 15, less than, like WHO latest thing has come, people who are less than 20 should should have 2 doses. So I think, with that kind of a thing, I'm very hopeful that if the maternal mortality can be decreased in this particular country, the people who have been saved by maternal mortality should not die because of the cancer cervix. That will be absolutely injustice. So I think with these words, it is open back to you, Dr. Sadhna.
डॉक्टर साधना, डॉक्टर नीरजा ने ज्वाइन कर लिया है. वेलकम डॉक्टर
yes.
नीरजा.
Welcome, Dr. Neerja. So, your comment, actually, we were discussing that what is the magnitude, and Dr. Sharda Jain already says that it is actually maybe the hidden more mortality and morbidity than the maternal death and the criticality. So, Dr. Neerja, you are like you are devoted to this field of oncology. Your comment and like your journey where we have come a long way in our aim for elimination of PCA cervix. Dr. Neerja, are you there? Then Dr. Shweta, you can.
Yes, yes. Thank you,
yes,
Dr.
Yes.
Dr. Sadhna, thank you. Can you hear me?
Yes, yes.
Yes, Dr. Neerja, welcome.
Okay. Thank you very much. And I just heard Dr. Sadhna's comment, Dr. Sharda Jain's comments, and really thank you for this invitation, firstly, to be here this evening. And Jyoti has been ringing me up so regularly. So, Dr. Ragini, so nice to see everyone. I'm not naming, but nice to see everyone on the screen. So your question really was about the cervical cancer magnitude, and isn't it? And
Yes,
it is something which I think now we have been saying it so many times in so many forums, that I think all the people are aware that cervical cancer is something of importance. Recently we've had this experience, everybody keeps saying how it's declining and how we need not to worry about it so much. There's some people who go as far as to say, why bother, वैसे ही कम हो रहा है. And in certain areas more than others, because if you look at the countrywide map, there's a lot of variation in the cervical cancer incidence, and it is as low as the Western countries in some places now, and it is as high as 27 per 100,000 in some northeastern states. So we recently had this experience that we have been working for some time now with a very new test which is being developed by Karen Anderson in Arizona State University, which is a serum test. And we know that the cervical cancer antibodies, the HPV antibodies, I should say, the E6, E7 antibodies, they don't come in all the patients. The antibodies come in about 50%. But still, we to see whether we could develop a test as a triage tool, which will just be a finger sticks test, was her goal. Now, for testing this out, we have been looking very actively for patients who are normal, who are CIN, who are cancer. And usually, we used to not find so many cases of CIN cancer because they get referred and they come. We could always find in our clinics, and there's no doubt that the cancer cases are decreasing. And CIN, very few we used to find just on random checks like that. But this time I have been really surprised that because we've been looking out and doing the tests on everyone and doing the HPV tests as a screening tool, and it is more sensitive, as we know, it is surprising how many CIN 2 and 3 we are coming across now. I think it's not right to assume with this cancer particularly that it is declining and it will continue to decline. I think there are many countries who have seen increases. It includes Japan, when they stopped this vaccination and they got lax on the screening and they showed recently. It includes in China, in certain provinces, they have seen remarkable increases, because it's also dependent on the lifestyle and the changing lifestyle of our youngsters. We will have a real problem if we are lax about this. If they don't go for regular screening, they don't go for vaccination, we can very well see an increase in the forthcoming time. So I think we are not only already, because maternal mortality has declined, so we are relatively seeing more cervical cancer. absolutely speaking, we are seeing less, but I am concerned that it could actually go up. I think we are seeing more CIN2 and 3 today than we ever saw before.
Thank you, Nirja. Actually, you brought out very, very important thing. That is something comprehensive, and that is the multiple sexual partner, increasing adolescent sexuality, use of tobacco and alcohol, which is very rampant nowadays, something social stigma, what Indian people have, it is not there. And very, very rightly says that it is, yes, of course, it is a vaccination screening, but we have to look at the wider frame that we can have to talk about the youngsters for the good lifestyle, and especially the safe sexual practices. And what is this is tobacco smoking, longer term use of COC is also there. So that is also the thing that yes, we need the population stabilization, but we have to be aware of it, and they might be needing the regular screening. And this is all we know, that it is 95% it is HPV vaccination, and we are not going to deal with the theoretical aspect because everybody is aware of it. Because before we go further, we like to have the comment of Dr. Shankar Narayan that what is the changing. Dr. Nirja says that yes, we are getting CIN. Absolute number of CA cervix, of course, it is decreasing. Dr. Shankar, your comment about this declining or the status quo, or what are the things which we have to be cautioned as a nation?
Thank you, madam. Thank you. Thank you very much. And that outset, I would like to thank all the organizers for the possibility to participate in this panel discussion. It's an important topic. There's no doubt about it. I agree with both Dr. Sarada Jain and Dr. Nirja, because we cannot be very lax, because there are some quarters, at least, say cervix cancer is declining. So there is no need to do improve hygiene and improve water supply and all those things. They are important, but on the other hand, we need to do something very specific. We cannot be complacent for the simple reason, as Dr. Nirja already pointed out. The lifestyles are changing, and there are lifestyle changes which may contribute to increases in human papillomaviral infection in future. And this is already happening. For example, China had a very low rate. By 1960s, 70s, in China, the incidence rate of cervix cancer was around 5 to 7 per 100,000. You can see the long-term trends in Shanghai, Shidong, and other cancer registries from China. Now, it has reached around 35 to 40 per 100,000, almost an 8-fold increase. From 2000 onwards, the rates are increasing. Actually, China has now overtaken India in 2022. China has overtaken India as the largest contributor of cervix cancer burden to the global burden of disease. It is almost like 142,000. That is the latest estimate for China, whereas for India, it stands still around 124. So these things can happen in India as well, because the generational changes, and already if we analyze some of our early HPV infection data by age groups, we can gradually start seeing an increase in the young population. So we have to be cautious about this. So we need to do preventive measures in right earnest. And I would like to congratulate the gynecologists and the gynecological societies across India, whether it is FOXI, whether it is AOGIN, ISCCP, whatever it is. And you have been very vocal about cervical cancer prevention, unlike many other professional societies. And the Indian Association of Pediatricians also are very supportive of the interventions we need to take. And the time is right. And we can sort out, we can list many number of reasons for a possible future increase, but the future increase can be realistic. And already, as Dr. Nirja said, if you go to Northeast India and some of the rural areas, the early trends are discouraging. The early trends are there is an increase in incidence rate to the tune of around 1% per annum, whereas in some parts of India, it is declining around 2.5 to 4% per annum. So whatever decline in some region we have may be compensated by increases in other regions. And particularly, if you remember that cervix cancer is the cancer of the poor women. And within India, with contributing the substantial proportion of people below poverty line, and the condition is ripe for any future increase unless we act promptly for prevention. From that angle, I think some of the policy decisions the government is taking now is really encouraging, and they have to be translated into action. For example, it's almost 5 months now after the government notified 7 states will go for HPV vaccination, 4 states with a single dose and 3 states with 2 doses. A very good development, but still the tendering process and all those things have to start, and the vaccination should start at the field level. So this is something which has to be speeded up. I think gynecology is very close to the government circles. That is what I feel always, because people have to be, childbirth is a very important event in life now, and the children are very precious. So your nearness to policymakers should be a valuable catalyst for speeding up this process.
Thank you, Dr. Shankar. So, Dr. Bala, you go ahead with the next question. Bala. So, Dr. Mala, so thank you, because, yes, please go ahead. I will be shifting the slide. So it is like what the Nirja and Dr. Shankar says, Dr. Shankar Narayan, that yes, you have emphasized that people with a normal cytology are also having the high and the low risk HPV type. And this is again a gap, because we are not really going to have in realistic terms the HPV testing for it, and that is the important thing. And this is just, I will say that what is we have been doing for all the interest for every audience, that 2008 we have the bivalent and the quadrivalent vaccine which was licensed in India. 2009 HPV vaccination demonstration project in Andhra Pradesh and Gujarat. Unfortunately, there were 7 deaths, which later were found that they were not associated with vaccinations, some food poisoning or some associated factor. But that was a major goal to the HPV vaccination drive in our country. Then India, our study says that the study on 2 to 3 doses of HPV vaccination and which start treatment. Then it was suspended in research study, but continued to be available on prescription in private sector. 2016, again, there was today we are talking of single dose. At that time, there was all research on the efficacy of 2nd and 3rd dose of HPV vaccination. Then Punjab in 2017 initiate HPV vaccination in Bathinda and Mansar district. Again, there was a similar efficacy, that 1 versus 2 or 3 dose reported. So what we are talking today of the 1 dose, which is very, very doable, that start from 2018. And how there is a state variation. Punjab initiated vaccination in certain districts, then Sikkim initiated a state-wise HPV vaccination targeting girls of 9 to 14 years. Then again, we have the Indian ARC study, which indicates 2 dose, and 2019 updated evidence from Indian ARC study. Again, it says that the 2 dose is as good as the 3 dose. And just last year, SIL, Serum Institute of India, launched the Cervical vaccine, which is the first indigenously made HPV vaccine in September 2022. So we can say that today, because today is our Indian Independence Day, that India is one of the biggest producer of vaccine, which provides a lot of vaccine to the whole of the world is, and we should be we should be very proud of it. So now the question is, we will say to Dr. Shweta and Dr. Ajay has not contributed. So we have always we find the question in all these chat box, which vaccine is good, it is a quadrivalent or it is nanovalent, or it is only now the Serum Institute, which is the key. So how we can, Shweta and Dr. Ajay, your choice, that how to answer that queries, that which whatever pharma people say we should use that, or something is there, and how to counsel about making them right.
Thank you, Dr. Sadhna. I think it is very important question pertaining to which type of vaccines. In India now, we are having 3 vaccines. Cervarix is not available in India now. GSK Cervarix is not available. So we are having 3 choices: nanovalent Gardasil, quadrivalent Gardasil, and Cervavac, that is quadrivalent. Now let me clear that first thing is to vaccinate, then to choose vaccine. We have to talk about the vaccination versus no vaccination. You give any vaccine that contains 16 and 18, it will cover at least in 70% of cervical cancers, 80% of anal cancers, 60% of vaginal cancer, 40% of vulvar cancer, and 90% of HPV type oropharyngeal cancers. So always I will say that don't restrict the HPV vaccine to only cervical cancer, because we have to propagate this HPV vaccine to the public, that it will prevent 7-8 type of cancers. We have to give this to the public. We have not restrict ourselves to one domain, that is cervical cancer. It prevent also anal cancer, vaginal cancer, oropharyngeal cancer, and also preventing wart also, those containing 6 and 11. Now regarding the quality is concerned, even our Indian Cervavac is having the 4 quadrivalent, which is having all non-inferiority trial. So there is no problem in choosing. Now the thing is, there are 2 different terms. One is private sector, other is national immunization program. In private sector, we have to give 2 doses as far as 9 to 14 years is concerned. From 15 onwards, 3 doses in private sector. I'm talking about the private sector. Now that all studies are breathing studies. When we did a study from 3 doses to 2 doses, now the same study continued, and we found that even 1 dose is effective. But still, the final results will come in next 3-4 years. Till that time, for our national program, because of vaccine availability, we can start in some states with single dose as far as 9 to 15 years, 14 years girls are concerned. And for your kind information, Cervavac is again gender neutral. It is recommended for male also, not 9 to 14, but 9 to 26 years. So the Cervavac is licensed for male as well as female, 9 to 26 years. Regarding nano vaccine, it is licensed in India by DCGI. The study was done only on 3 doses. So as far as nanovalent is concerned, the study is not in India for 2 doses. But now the IAP body itself in guidelines 2023 suggested that we can give nanovalent also 2 doses. But DCGI approval is only for 3 doses. So one should be clear in choosing the vaccine, and you should have clear-cut DCGI guideline. We cannot use nanovalent vaccine for male child of 18 years old, because it is not in India approved by DCGI. It is approved up to 9 to 15 years only. So Cervavac is advantage that we can use up to 9 to 26 years as far as male child is concerned. And we should always tell the parents that it will cover the penile, it will prevent the penile cancer, scrotal HPV carrier state. So if we are vaccinating male, we are not only giving the direct benefit to the male, but also increasing the herd immunity, and male can be a carrier. So our aim is, first aim is to vaccinate girls 9 to 14 years and male also, because we have to cover the male also.
So thank you very much. The very, very important point. Any vaccine is good. You can choose, but vaccination should be must. And the second thing that yes, of course, when there is a low cost, we can give benefit, and in private setting, it is okay if the people are ready for it. And coming to the slowly targeting, because actually the boys, yes, of course, and like in our forums, it is very good that we say that can be applied to boys, but we have to many hurdles in our country even to get even the primary target, who are the adolescent girls, and the 9 to 15 and 15 to 26 and then onwards. So there are a lot of bridging, and the male vaccination HPV, actually it is not the vaccination. We have to cross many barriers, social, like about the sexuality, adolescent, and the awareness and why it is there. So a lot of things to do. So Shweta, you have not contributed, and we always need the young people's input about it, that we have the indigenous vaccine now. We are a proud producer of it. Important thing is that how to optimize the use of vaccination. So this is from Shweta, and then we come to
one thing I would be very not agree with Dr. Arora is that whether it is a private or a public sector, we should have one kind of norms for everybody. And if we are sticking on to one dose, it should be one below 20 years, and it should go, the message should be clear to all, rather than being a dual nature, that if we are in the clinic, we are saying 2 doses, and if we are in a camp setting, we are talking about 1 dose. So this should be clear, because if we are sitting in the clinic and giving 1 dose of Cervivac, or maybe it is not still licensed, the studies are not there, but if we are giving a Gardasil and we are saying it 1 dose, then we should say it with conviction that yes, 1 dose is effective, rather than in some patients, in some setting, we say 2 doses, and in some setting 1 dose. And now to the question which has been allotted to me, that Cervivac, an indigenous vaccine, now that we know that around 68 million doses of vaccines are required for this catch-up vaccine in this group of people. So, and with the new vaccine coming in, Indian vaccine, and a single dose, we have a very good hope to cover the whole population. Cervivac, if we talk about, it comes into twin doses. In one vial, there are 2 doses, and the cost is around 4,000, and to doctors, it is around 3,200. It is very important sitting in the clinic, not in the camp setting, that we always promote and sort of encourage 2 girls coming at the same time, because once you use a 1 dose, you have to discard if it is not used within few hours. So it is very clear that 2 girls should be vaccinated at the same time. And this is the difficulty which we private practitioners are facing, because once we open the vial, it is like wasted if it is not used. So I usually, sitting in my clinic, I ask 2 girls to come together and tell them the benefit of the economics that they will have if 2 of the friends or 2 of the daughters are coming together to get this vaccination.
So thank you, Shweta, for very important, and that is the diversity of opinion is something what we look from the panel, that we should have speak one voice for everybody, because again the public people say that we are getting at maybe the less optimal thing, and the 2 dose might be effective. And secondly, the 2 dose, that is something very practical thing that we are wasting around, and it is not that like a very cheap drug, so we cannot afford to waste that one. And we can say, like, this is again advocacy beside in the community, that the serum people can have the single dose vaccine as well. I think that will be maybe a little higher cost. So 2 things very, very important. Dr. Ajay, we will come to you. That for children, whatever vaccine it is, Rotavac, like over the 10 years, I say the vaccination list for the children are increasing, and parents happily doing for it. How this vaccination is different from the adolescent girl, which is for the like something distant thing about the sexuality, and how it is about something about the girl and woman reproductive health, and something all child vaccination every parent accept, whatever cost it is there. So Dr. Ajay, you just guide that how we can really bridge that mental gap in our community as well. That it is important, and the child health is important, but not the girls' reproductive health or the couples, male and female reproductive health. Your comment about.
Very good question, Dr. Sadhana. You just asked very good question, because if you compare the DPT vaccine, pneumococcal vaccine, Rota vaccine, the coverage of DPT vaccine over 10 years increased to 85-88% globally also. If you see HPV vaccine, if you see globally also, it is only 13%. Globally also. So you cannot compare HPV with pneumococcal, which comes in the same time and reach up to the level of 52, 56%. But HPV again at 13%. And we have not touched a very important setback of COVID-19. In 2020, we have a rapid decline as far as HPV vaccination is concerned, because in Western countries, HPV vaccine is given in schools, and during COVID, when all schools are closed, so the HPV vaccine, they suffered a lot. So there is a sudden decline. Now, very important question, why this is not picking up? The basic thing, what I told Dr. Sharda also, that we have to combine Foxy and IAP together, because this is the age when pediatricians are totally done with the vaccination, 9 year, 10 year, and gynecologists start their checkup in the girl child around 14-15 years. So the transition gap between 10 to 14 years, neither with pediatrician nor with the gynecologist. And we are coming up, like Fox is doing so much, IAP is also doing so much. IAP is coming up with a very good program, that is Saksham. This Saksham program is to sensitize all pediatrician and gynecologists, as well as going to school and giving health talk on HPV vaccination and promoting school children for HPV vaccination, which are 9 to 14 year old. So our target is 9 to 14 year age group, and Saksham is a very good model developed by IAP. And I think we, along with Foxy, if we combinedly do this, promote this vaccination, we can achieve this. And the presently already government is also doing a good job. 6 states, they have already started in June 2023, that they included 6 states for this national immunization program free of cost, and they also invited tender, but it will take time, and from 2026 it will be available free of cost. But till that time, Foxy and IAP should do something to initiate the basic awareness program, so that when the free of cost vaccine is available, people will be ready to take that. We have seen that in COVID, our vaccination, as far as India is concerned, we are having very good vaccination rate, because India is the only country which is having 27 million birth cohort already taking vaccination under UIP, as well as 29 million pregnant women taking tetanus, TD, Tdap, and TD under the government program. So we are having good vaccination backup. Only we have to promote the things in a proper way.
So thank you about that. That Saksham, Mala, you go ahead. Because
Yeah, I
it's a
wanted to
very
say
important
something.
topic. Yes, yes. Mala.
I wanted to say something like Foxy and DCGI. They have told 2 doses between 9 to 14 years and 3 doses 15 years and above. But WHO has promoted an alternative dosage, which is an important message to be given. WHO has proposed an alternative dosage that between 9 to 14, 1 or 2 dose, 15 to 20, 1 or 2 dose, and above 20, 2 doses. 21 years and above, 2 doses 6 months apart. This is what has come in WHO position paper in December 2022.
I think Dr. Mala pointed very well. That is the MAC. That is multiple age cohort. It means from 9 to 14, you give single dose and follow up, because we want to save there's a demand and supply thing. So WHO come up with a very good formula that 9 to 14, you give 1 dose and follow up, that is a 15 to 20 years. You in multiple age cohort, you do vaccination, which we did in MR program. That 0 to 19 years, we gave 0 to 50 years, we gave 1 single dose of MR, irrespective of previous vaccination. Similarly, WHO come with the same formula that you give 1 more booster the vaccine after the 5 years, so that the shortage will not be there. And that's why I told that we cannot go for single dose vaccination, because the paper is still not out. The IRC committee is still working on that. So many countries are doing the job. WHO is saying we can go for it. But as far as medico-legally concerned, still in India, 9 to 15, 14 years, we have to give 2 doses. We cannot promote single dose till we get the approval from DCGI. Thank you.
Nirja, Dr. Nirja, we will like to have your opinion. Another very, very important question. So it is still what Dr. Ajay says, that it is better, it is a 1 or 2 dose, which the WHO is updated recommendation. Many women, actually gynecologists, women, yes, there is no vaccination for adolescent, even for 15 to 20 years. Many women at the 30s, 35, when they have vaginal discharge, and they say, oh, this is ये cancer cervix की vaccine है, ये हमको लगा दीजिए. So, Dr. Nirja, your comment to gynecologists, what the gynecologist should do efficacy is less. We don't know about its utility, how far it is effective. So, Dr. Nirja, your comment about this. With the women older than 21 years, or we will say the very common demand request that 30, 35, they don't want a screening, they don't want other thing, but they say that it might work for the cervical cancer. So, Nirja, your comment about it.
Well, I would say that it really, it's not absolutely, it's just not right that they should want only vaccination and not want screening.
Yes.
And that is something which we have to really try and persuade. And today, for such affording people who are willing to buy the vaccine, we have the option of self-sampling for HPV testing, even if they do not want a checkup by a doctor, they don't want a speculum, let's suppose, then at least we can offer them a self-sampling vaginal swab, HPV testing, and even one such at 35 will have some value for us, I think. So I have to say that this very small number that I have found that fit this category, there are many who are willing for screening and vaccination, but there are very, very few who say, just give me the vaccine, I'll come some other time, including some doctors. But then usually at some point, we do manage to sort of rope them in later for a screening. But just to give the vaccine alone, if the patient is insisting on it, recognizes what the downside is, I suppose there is an option of freedom of choice. But it has to be very, very well documented by us also, because it could have medical legal implications later on. These are the type of people who will come back if at all they develop any problem and say, they didn't really tell me that this was what could happen. I never knew if I had, I would do it. And also a very clear consenting is required.
That's why, because if we give the vaccine right around 30s, we have to say to the patient, like the whoever is receiving this vaccine, that the efficacy is not that good what it has been before the like start of sexual debate. So this is very important, because false idea of security and they are not going for the regular screen or the checkup. This is a realistic point in the clinical practice. Shweta, your comment about it, that the woman in the reproductive age in 30s, for gynecologist role, that how we should counsel these women for the HPV vaccination, if at all we are giving to them.
Dr. Sadhna, I want one thing.
Yes.
Dr. Nirja Patla is here, Dr. Shankar Narayan is here. Let this for adolescent thing should be sorted out, 1 dose or 2 dose. They should be sorted out by these two experts who are here.
Nirja and Ajay, yes.
Please.
So I think Dr. Shankar will tell us what he thinks on this.
Nirja, you gave the balls to Dr. Shankar. Yes, Dr. Shankar, your comment.
Thank you, Dr. Major. Thank you, Dr. Sadhna. First thing I wanted to clarify is the WHO new recommendations, the SAGE recommendations WHO is following now, is not exclusive. It says between 9 to 14 years, it's a single dose or 2 doses. Why this ambiguity, 1 or 2 doses? You have to remember the WHO policies are taken by an international group of experts. Just like in the panel we were differing, in the working groups also there will be a lot of difference of opinion. So the decision has to be taken democratically, and that is why this ambiguity comes. That doesn't mean that 1 dose is useless, 2 doses is used. No. If there is a preference there, there is a cocktail, there is a menu there, you can choose 1 dose or 2 dose, both are same. So if somebody is saying both are same, why do you want to spend more money? So that is logic. Okay. So 9 to 14 single dose is highly recommended now by WHO. The second point, adolescents between 50 and 20, again the same recommendation, a single dose or 2 dose. WHO recommendations are not based on cost considerations and other things. It is based on efficacy, because efficacy is the ultimate yardstick for measuring the utility of a particular intervention. It is not, cost comes later. So even for this particular group, 15 to 20 years, single dose or 2 doses, it is definite. So I am a proponent of a single dose. Why? look at the India IR trial. When we recruited them, they were aged between 10 to 18 years. The 18-year-olds have now reached 30 years. Okay. And the 10-year-old girls have now reached 23 years. So a lot of information is being collected. It's documented in literature, and you will see some of very interesting papers in the next few months. And it all shows an excellent immune response by a single dose. And the evidence is very consistent. Not only from India, from Costa Rica, from Africa, and from routine programs in Australia, Nordic countries, United States, Canada, UK, and everywhere where people default with a single dose, they are doing exactly the same way as the 2 doses or 3 doses. So the evidence is very strong as of now. And this is again because this vaccine is a potent vaccine. It induces antibodies more than any other vaccine. The vaccine memory is quite good. You can see the literature studies where they are talking about avidity, the proportion of long surviving plasma cells, which are very important for immune memory, and the production of antibodies when a challenge happens, and all those things. So I would definitely say, let us be very dogmatic about it. The dogma is in favor of a single dose for people up to 20 years and 2 doses above the age of 20 years. Even if you see the WHO recommendation for HIV infected immunocompromised people, wherever feasible, you do 3 doses, but otherwise 2 doses is sufficient. And this is again because of the differential opinion in the panel. So they give you a democratic decision. So even for HIV infected people, it is 2 doses, is as good as 3 doses. So, if you look at the evidence, it is very clear. So adolescents, a single dose. But somebody wants to give 2 doses, it is up to them. Okay. But on the other hand, you cannot say 1 dose is inferior to 2 doses. So look at the logic there and use the logic when you prescribe. It is not that the 1 dose is recommended for 15-20 because even if they are vaccinated between 9 to 14, or they can receive the second dose by the single dose. No, they are absolute recommendations. If you see somebody de novo between 15-20 years, give a single dose or 2 doses, depending upon your conviction. Okay, it is not that they have received 1 dose between 9 to 14 and then you give the second dose between 15 to 20. No, these are absolute recommendations. And WHO recommends, after quite a lot of discussions in international working parties. In fact, the WHO Secretariat has very little role unless when voting comes and there is equity, then the WHO Secretariat votes. So these are fairly independent opinions. So I will say I will vote for 1 dose for 15 to 20-year-old girls. Based
What
on
about Cervavac?
what
So
about,
what about if we are using Cervavac?
okay. The Cervavac 1 dose trials are going to start. What is the comparator vaccine with Cervavac? Okay. The comparator vaccine with Cervavac was the Merck Gardasil 4. Okay. And in a randomized clinical trial, you compare with a comparator, and the comparator has been shown to be, most of the coming evidence for HPV vaccination is going to be historic, bridging, immunobridging, and all those things. So if the comparator is doing very well with a single dose, logically, the one which is the experimental vaccine should do as well as the comparator vaccine. Okay. There is plenty of information for Gardasil, much more than Cervarix. Gardasil 4 single dose information is quite large because many of the national programs started, and the United States only almost 30-40% in the single dose only in the routine program. So
just my question.
Let me finish them.
Yeah.
So the licensing by DGCI is a very important consideration. So the licensing will be like 2 doses. The Cervavac has been licensed for a 2-dose schedule. Okay. But as an individual, for example, the government is going to vaccinate in 4 states with a single dose. Tamil Nadu, Karnataka, I think Mizoram, and 1 more, Himachal Pradesh. So the government takes a decision, give a single dose based on scientific literature and WHO recommendations, while the DGCI recommendation, the dosage labeling is very different. Okay. So the label will show something, but it doesn't prevent anyone giving a single dose. I think the pharma companies will be very angry with me when I say these things. But
Yes.
you have to apply logic. Okay. So what is the danger? Suppose you give Cervavac a single dose, and then after some time the report comes that it is not working very well. For example, the randomized, it is unlikely, but if it happens so, you give the second dose, even after 2 or 3 years, it will do good. So there is nothing to prevent, and maybe provocative, nothing to prevent giving a single dose of Cervavac to someone, even though the national licensing labeling is different. Okay.
So Dr. Ajay and Dr. Nija, your comments.
Just-
Yes.
Yes,
Just-
definitely.
I totally convinced Dr. Shankar because as a immunology student, I know that with the bridging study, we know that single dose is equally effective. Up to 20 years, they have done a study, and I totally agree with Dr. Shankar that WHO is concerned. But as far as PI practitioner is concerned, DCGI approval is important. He mentioned also, as a government, the policy is different. For example, in all immunization program, the government policy is different. For example, pneumococcal, so we give 2+1 as far as government is concerned. But in PI practice, we give 3+1. So DCGI approval for one dose is still not with anyone. Second thing, Cervavac is only licensed for 26 years of age. So your previous question, that 35-year-old lady asking for vaccine, for the cost benefit, if you give Cervavac, you may be medico-legally liable for that because the study is not done on Cervavac about 26 years. So you have to think the particular label also as far as DCGI is concerned. Science is something different, and DCGI approval for your practice is also different thing. So I totally agree with Dr. Shankar, and I request Dr. Shankar, please tell Government of India and DCGI to give this approval for single dose, so we can form a uniform policy, because unless and until DCGI will not give this approval, we cannot give in our immunization book that we can give single dose from 9 to 14. Still 2023, IEP book said that you have to give 2 doses because there is no approval for DCGI. So I request that Foxy and IEP, along with Dr. Shankar and some other people, should approach DCGI for this approval. Thank you.
Nija, your final comment on this very, very important one versus DCGI and the versus efficacy. Your comment. Yes.
So I would agree with the points raised by both. Both have said it really, really clearly. But Dr. Shankar's point is absolutely the scientific one. And we have to realize that one dose is likely workable. And also the point raised by Dr. Ajay is very right that it is an off-label. So the patient can come back to us and say, you did not follow the label. So in a national program, the situation is decided by the government, and that carries weight in itself. And in fact, I think once that program starts, it will give a lot of confidence even to the individual practitioner to follow that. The DCGI cannot give the permission till the data comes. The data will take time because the WHO has said that the stability of the antibody should be demonstrated at 2 years. So it will be some time before the data comes for Cervavac. So I personally feel that as a middle path, what we can do is to offer one dose. And as Dr. Shankar said, we should inform the patient that as of now, the data is not mature. We will check back with you again after 2 years once the data comes, whether you do or do not require another dose. So anybody who is not willing to take the second dose or is not affording, so long as we are able to track those patients, so long as we are able to recall them, and mostly even if we are going with some school programs or something at this time, you know, some NGOs are wanting to do and all, it's not difficult because these young girls who are in class 6 or something maybe now, they will still, most of them, be in the same schools 2 or 3 years down the line. And this is what very important, what Dr. Shankar has said, that it's not a fixed thing that you have to do it at 6 months, the second dose. And this is what has been seen also in the India IR trial, that even when they were given the second dose, 18 months or more gap later, they had the same level of response, comparable. And same policy was, even Dr. Shankar will know this even better than me. In Quebec, they had started a program where they had said that we will give the second dose at 5 years. So that is also a very good sort of a plan, that you plan it that way, and then you know by then that the data has come. So if not 2, maybe we say 3 years down the line, we are going to connect again and let you know whether your 1 dose is fine or whether we have to give you another dose.
Actually, after 1 year, or we can say it is not a like a dose vaccination schedule. We may say it is a booster actually. It is not 5 year. It is a like a vaccination schedule. It is
The second dose, I mean, we may call it whatever we like as a booster or whatever, but that is exactly what the second dose does, is to do a booster action on that.
हम सोचते हैं, हम ये कह सकते हैं कि एक काफी है, और अगर 2 है तो बहुत अच्छा है. We can say एक काफी है, लेकिन है तो 2 है तो बहुत अच्छा है.
That's right.
As a clinician, we are like quite clear, transparent, as well as the like communicating that this thing that the first 1 dose is quite good. So Mala, go ahead with the yes. So
and I think what it implies is that our gynecologists and our pediatricians should be encouraged. Pediatricians are very good at this already. They keep very good registers. But for the gynecologists, they should keep a very good register of the patients whom they are vaccinating, be it the young adolescent girls. And, you know, there are several who fall in our patient group also, patients who come with PCOS or puberty menorrhagia or whatever. We see enough numbers also under the age of 20. So we should maintain a very good register so that we can follow up our patients and know what's happening. And this is not important only from perspective of giving a second dose, but is also important in the perspective of following up, seeing the efficacy of vaccination, linking with the cancer registries. You know, a movement to have vaccine registry is a very important one.
Thank you, Rija. Thank you. So Mala, go ahead with a few simple questions, and after that the challenges. So Mala, go ahead. The simple thing, this is for Shweta. Mala?
Yes, Dr. Shweta, how do you counsel the girls and the families, and how do you administer? It has to be given intramuscularly. How we have to guide the obstetrician also, how to give the vaccine.
Counseling is very important, and I think with a lot of social media coming in, it is not now difficult also. But the first and the foremost thing is that the doctor should be convinced, and we should not label it as a cervical cancer vaccination. It should be HPV vaccination. Not much of information should be given, only that this is a vaccine which will protect against this virus, and the benefits that the child will be protected from so many cancers, rather than involving words like sexually transmitted. These words should be omitted very clearly from the counseling part. And even if you counsel a postpartum woman to take the vaccine, she will definitely go back home, tell all the girls that, yes, this vaccine was for you. I always counsel them, telling them that because when you were at 9 or 14 years, this vaccine was not available. So you can take it now, but whosoever is between 9 to 14 years in your family, you should tell them to come and vaccinate, because at that time, the efficacy is more than 95%, almost equaling to 100%. And but if you take at the postpartum period, it is very important to tell them that the efficacy is not that much as that of young girls. And it is a vaccine which is given IM 0.5 ml over the deltoid, and most of the times there are no side effects, though syncopal attack is reported in a very few % of cases. So I usually tell them to wait for 10 minutes in the clinic before the patient takes a leave. And apart from that, a little pain, which is usually subsides with a crocin.
So one thing very important, actually, what we are missing, Shweta, this is very important, because I also say it is HPV vaccine. I never say it is an anti-cancer vaccine. So again, we will come to this, that for something like increasing acceptability, we say, yes, there is something what we can say, something, a remedy for the CA cervix. So comment from Dr. Ajay and Dr. Neerja, that it is a HPV vaccine or it is a cancer vaccine. And the second thing is that it does not protect against all type of HPV, because there can be more HPV, and women who have been vaccinated are advised to follow the same screening recommendation, whether they are vaccinated or not. And here is the trick that how really we can, like, because it requires a lot of time to convince about all these things. Then why? So the Mala, you take away and the like
Basically,
discussion. And
when we tell the counseling of the patient, we tell the patients that it is one vaccine, 2 doses, prevents 6 cancers. That's what that can be 6 conditions, not cancers, 6 conditions. Like it includes warts, it includes cervical cancer, it includes enogenital warts as well as it also prevents respiratory papillomatosis and oropharyngeal cancers. That is how you counsel the patient, and you also tell them that routine screening has to be done even after taking the vaccination, at least at 35 years and 45 years. That is what we are trying to tell the patients, that at least 2 times after vaccination, you have to come for screening either by cytology or by HPV vaccination. And then there is a cost factor as well. The patients have to be counseled that monovalent is costly, but quadrivalent is not so costly. And the indigenous Indian vaccine is definitely very cost effective, but of course, it has a limitation because once you open the vial, 2 persons should be available to take the vaccine. Though for 1 person, it is very cost effective, and we have to plan in such a way that at least 2 persons are present at the moment when you're opening the vial. And we all know this vaccine is very safe, and we can give vaccination with other kind of vaccination as well to the adolescent girls. That's what Dr. Arora will be telling, that there are very minimum side effects and it can be given with other vaccines as well.
And the fainting, this is the especially in the adolescent, they just get fainted out of everything. So always take that they are well seated and allow them to wait for 15 to 20 minutes.
Yes.
So this is important because, you know, vaccine, contraception, we have to be very, very particular. A single negative thing and a lot of negative thing in our Indian society or mohalla, सब लोग एकदम से बोलते. So as a doctor, we have to be very, very careful about it, that it is safe. Now safety is very very proven and not a much side effect. One expert comment I will say to Dr. Ajay Arora, that is a controlled temperature change. So the vaccine is always to be kept in 2 to 8 degrees. And there is some innovative way that because it may be the school vaccination, it may be the rural panchayat vaccination, it may be something like a prostitute area where we have the high risk. So your comment about this thing, that vaccine to be kept in a like outside for a certain period of time so that we can really reach the marginalized population. So Dr. Ajay, you are the best person to answer.
Yes, madam. Nowadays, our Indian vaccination program UPI is so wonderful that even the Anganwadi worker is having that carrier that contains the cold chain completely, that maintain that cold chain for at least 6 to 8 hours. We give that carrier to our Anganwadi worker and other people going to the field also. So as far as cold maintenance is concerned, we have to vaccinate only in our clinic, and we should not encourage that you purchase vaccine from outside and I will give it to you. That is very important, because if patient is taking that vaccine from some person, keeping that vaccine in a drying room for whole night, coming to you with proper cold chain, and you don't know the efficacy. So I think we should not encourage outside vaccination. We should always say that you have to take the vaccine from our premises only. We not allowed you to purchase from outside. Second thing, cold chain, we have to tell clearly to our staff also that when the patient is ready, then only we, as far as pediatrician, we are vaccinating ourselves. We are not giving even to our sisters for vaccination because pediatric age is concerned. Third thing, very important point, you mentioned, Dr. Mala also mentioned, I know that most of time in anti-rabies vaccine, people give in gluteal region where the vaccine efficacy is hardly 5-7%. And we know the case fatality rate of rabies is 100%. So even a patient come for anti-rabies vaccine, I told that if you took this vaccine in gluteal region, I will not count this. I will give further 4 or 5 vaccine depending upon the schedule. So it is very important to give in deltoid region or in younger age group anterior side of thigh where muscle mass is more, not to the gluteal region. It is big no for gluteal region. And second, that very well pointed out, Dr. Mahara, that we have to promote this as a prevention for 6-7 diseases. And we have to say that prevents 70 to 80% of different cancers. 100% prevention is not possible. So you have to go for screening. Nothing is 100%. No vaccine is 100%. We always say it is 70 to 80%, which is very good number. Any efficacy 70-80% is very good number. And people now ready to accept that because even after COVID vaccination, they were infected in second attack, third wave also. So we told that the severity is less, but nothing is 100%. So I think the proper counseling is important before vaccination. And second, keep that girl in your chamber for 5 to 10 minutes, because even just after taking the vaccine, if they wait outside the chamber, and sometimes going to from your chamber to the outside waiting area, the gun may collapse because of vasovagal or some fright. So I think it is important to keep that, to ask that girl to be with you for 5 to 10 minutes in your chamber only.
So very important, because why we have put this simple question, because pediatricians are very accustomed to have the vaccination, and now we are having this adult vaccination program. Like there are many things which we can offer to adult. We gynecologists also have to have that, like all set up in our system: pharmacy, register, vaccination, where to give deltoid, how to keep our sister, and that will be actually the reorientation, because as a IVF we are having such a particular concern about cold chain, and that same concern we have to have about the vaccine. And that is very important mindset of the changes, because pediatricians are doing their, it is in your like a genetic, it is something hard disk, but it is not in a OB-GYN hard disk where the pharmacy may be different and she might be. And very, very important that don't purchase from outside. It is not that you write this vaccine, she comes from anywhere where the electricity is not there, generator is not there, and we are giving vaccine. So few very, very important comments. And about this, we are coming to a little bit again rebound that how is this different from the other vaccination, because actually there is the gap. We are having a strong voice, but in ground realities, as you say, globally it is around 30%. As a co-chair SEPOG NCD committee, Bhutan is the country where they have achieved 100% vaccination for their girls. So it is doable. So we don't have a existing service delivery platform. What he said, Dr. Shardagan, a very strong advocate, and everybody says that the one-shot vaccine is very important. And this is the sensitivity around HPV vaccination. So we have to talk about the sexuality whenever there is we talk about vaccination. So it requires a communication, social mobilization, complex coordination and communication, and we have to find the inclusive new mechanism that how to talk about holistically about the reproductive health. We have a lot of barriers in reproductive health for our young people. So we want to have comment from Shweta. You are a young person, you are always keep innovative, and then Nija and Dr. Prashad. These challenges, these are, so what are the challenges? How the HPV vaccination is not the other vaccination, it is not a COVID vaccination. So what is the like the hidden hindrance and the challenge?
Ma'am, the cost is the greatest challenge.
Like all over one, globally it is not. So cost, yes.
Cost is the greatest challenge, and then awareness and the coverage. To as everybody is talking about single dose and to cover to masses to bring about the herd immunity, the coverage is also a major cost in a country like ours, which is such a vast country. Coverage, unless and until the government comes into picture, is very difficult. We as private practitioners can just create awareness, but for the coverage, government has to be a part of it.
So very rightly says, so we have actually the GAVI, that is the Global Vaccine Action Plan, and the like a global action plan for prevention and control of NCD. So Shweta repeatedly says the cost is the thing. And to my experience, when we talk about all these things, they say it is a very remote, and we are really hesitant to talk about sexuality in that age group in their families. So the international coordination is also very important, because Gavi, they provide a low-cost vaccine to the developing countries. This is also the way ahead, and we have our own indigenous vaccine, and we have the first trial going on, that it is safe and it is effective. Trial will take a little time, what Dr. Nija says, and that what is integration of HPV vaccine with the other health services. So with the other vaccination, with the other health services, and there is the scope. When we will talk about HPV vaccination, we will have the new opportunities to bridging to the talks about all many things which we should have been talking to adolescents. Maybe it is tobacco and substance addiction, maybe it is a mobile and the gadget addiction. So this single point can open up the new opportunities for our country, that we are the youngest population. We are going to lead because we have the youngest population. And as a doctor, as a human being, and as a leader for our own areas, it can be a really like an opportunity to open up the gaps in the reproductive health care. So finally, with a wonderful panel, every panelist, we will say your message on Independence Day. North India Gynae Forum is committed to the cancer cervix-free India. It is one of the topmost priority. And let us start from our home. So we will start from Shweta Young, and we will end with Dr. Sharda Jain. Your message that how we can make our India cancer cervix-free, vaccination and beyond vaccination.
So, ma'am, to create awareness, I think, is the first and the foremost thing. Once we are aware, the one who is educated has the power. So create an awareness, whether you vaccinate or not, but once you create an awareness, they will talk to 10 more people and the chain will go on.
Thank you. Nirja?
Is not here.
Nirja is left here. Dr. Shankar.
Dr. Shankar.
I think I agree with Sweta. We have creating awareness is paramount importance. And then again, one of the important things we need to do is increase the competition between the manufacturers and reduce the vaccine prices. Actually, Sweta made an important point a little earlier, that the government actions are also very important. But if we learn from the COVID experience, a lot of COVID vaccines were given by the private sector, and that is what improved the government coverage as well. So the private sector coming in a big way has a cascading effect with the efforts that the government sector makes, because there is a certain cross-section of the society which will not go into public programs. It's unfortunate, but it is the reality. So, your efforts in increasing awareness among gynecologists, pediatricians, the general public, and all those things are very important. And ultimately, we should encourage more manufacturers to come into place, and then with better formulations. For example, the 2-dose formulation by Serum Institute is quite challenging, actually. And we should promote vaccines, particularly the adult vaccines, like single-dose vials, single-dose preloaded vaccines. That should be the format that we should be, vouching for. And then again, of course, we have to also put the emphasis on screening, because that is complementary, and screening and treatment, because this will add to the entire prevention efforts. That these are the areas where we need to concentrate as we go on. The private sector role is very important, and and I would also congratulate Dr. Ajay, for bringing the pediatrician's viewpoint. It is very, very educative. And we should adapt some of those practices which are being done by the pediatricians in improving our services for cervical cancer prevention. Thank you.
Single dose manufacturing, our own indigenous, and the inclusion of private sector. Great. Shweta for the awareness. Dr. Ajay, and final comment from Dr. Sharda. Dr. Ajay, your message.
This is very good program. I think I congratulate Dr. Sharda Jain to incorporate pediatrician also, because Foxy and IEP together can do this job. And I think awareness is very important. We have to do awareness in schools also, to public places also, and we have to put some posters regarding the prevention of cervical cancer, like we are having poster for different type of cancer. So as far as cervical cancer is concerned, we are far behind than the breast cancer people. So we have to propagate this. This is the second most important cancer. Second, for immunocompromised, I think you should not try one dose. You should give 2 or 3 doses, because immunocompromised is different group. We are the we cannot go with the single dose vaccination. And I think with the Serum Institute also coming with single dose in the next 3 to 4 months, because I talked to very senior people there. They are coming for the single dose, because this 2 doses for the government supply, because there's so much order from the government. So they made this 2 doses vial. Now they're coming up with the single dose vial also. Similarly, if we get more players, the cost will come down. Basically, I know from the other side of table, if you're on the other side of table, to give $10,000 for single vaccine, and that also for 3 doses will ultimately shake your budget for a lower middle class family. So it is very easy to write that go purchase, please take this nanovirus vaccine. But if you see the cost, it is not affordable for so many families. 10,000 every dose, that also 3 doses or 2 doses. So I think cost factor is very important. And Dr. Shankar told very well that we have to invite more players, because till now worldwide only 7-8 players are there who are manufacturing this HPV vaccine with different name. China is having different, other countries having different name. So only 7-8 players are there. If more players are there, then we will have definitely less cost.
I think one very important thing which have emerged in between, I'm reading like in between line, that the schools, like now, which is a overall opportunity, HPV vaccination, good sexual practices, safe sexes, and involving the teachers and the girls by their own. So this is something which I have read in between line, all the messages. Final message from Dr. Shardajan for all, how we can make our country, really it is a reality that our country remains CA cervix begin 2030. Ma'am.
I think this is a very important message. In fact, my clarity has become 100%, today when Dr. Shankar Narayan and Dr. Neerja Batla has spoken of their mind about it. I'm for single dose. We have to ensure that the adolescents, by 15 years, we start at 10 years, by 15 years, everybody must be covered. As far as WHO guidance to the Ministry of Health is concerned, if they are going to include this particular national immunization program, I was told it's a 6 months time, they are looking for the tenders, and probably by March 24 things will be rolled out. I'm sad now that, Dr. Arora says that it will be started in 2006. I learned from pediatricians almost 3 years back, this vaccine should not be sold as cancer cervix vaccine. It should be sold as cancer vaccine. And I think, I learned it long back. And whenever my lectures are there, I always tell that you must promote it, that it is one vaccine, 2 doses. And now from 2 doses, it has come to 1 dose, and it can take care of 6 things. I think, unless the government chips in, we will not be able to do that justice of 90%. We can only do a small section of people who are coming to us. We can make sure that they get the vaccination. But short of government bringing it in the national immunization program for girls, probably things will not be possible. We can tell our ladies who come to us that your boys also need to have vaccinated, and now the vaccine is available up to 26 years, and the boys should be vaccinated. But I will definitely say that we must enforce, as far as the screening part is concerned, must at 35 and 45 years. I have a doubt that, this HPV vaccine related test will be available to us in a matter of 6 months or 1 year time. Till that time, I'm all for VIA and Willy. And I think, VIA is ₹1 test. And if you combine it with Willy, it is a ₹5 test. So I think I am a proponent of using both. VIA, because it gives me 60% clarity. But when I use Willy, then it gives me 100% clarity. And I think, that particular program, it should be single visit program. as for the cancer cervix is concerned, in the rural areas and things like that, because the patient is not going to come back for follow-up. Whatever up you have to do it, you have to give this particular thing. Now, last thing which I have again not have clarity, Dr. Shankar is here on the treatment side. When a patient has CIN3, I attended a course with the English professor, and he said in developing countries like India, whenever a patient has completed their family and she is found to have CIN3, they should not be advised on a conservative treatment, because this is the lady who's not going to come back for follow-up. And this is the patient we should definitely advise hysterectomy if she has completed a family. I will definitely like to have opinion from Dr. Shankar Narayan as far as this part is concerned, because there is a difference of opinion. About 10 or 12 consultants, across the country are hammering this. No, this is possible, and this should be there. So I think I would love to have last comment before we close this thing from Shankar Narayan as far as this treatment part is concerned. I'm very hopeful. If the government has given in guidelines, it will probably, the program will come in earlier. And I think, pediatricians and gynecologists put it together, then it should be part of the 24 things. So I think people like Dr. Shankar Narayan must be knowing what is the strategy of the government at this stage. I was told it is 24 March.
Thank you, ma'am. Actually, we have quite a lot of experience in managing CIN3 cases across the world. I think cumulatively, we would have managed some 7,000 to 8,000 cases across the world. And we have used only 2 modalities, either 3 modalities actually. In the beginning, we used cryotherapy for all patients, irrespective of the grade of the CIN, including CIN3. If it is totally ectocervical, involving less than 3/4 of the transformation zone, no clinical evidence of cancer, and no involvement of the canal or the vagina, we have treated them with ablative method. So in the beginning, we used cryotherapy, but now we have completely switched over to thermal ablation. And it is as good as any other modality. And then for those large lesions involving more than 3/4 of the transformation zone, or type 2 transformation zone or type 3 transformation zone, we prefer loop electrosurgical excision procedure. There is nothing to suggest that in people who have completed their reproductive age, one should go for surgery and all those things. There is no scope for that actually. The only indication now for carcinoma, for golden knife conization, is that where you strongly suspect a microinvasive cancer, where you will need a large chunk of tissue for the pathologist, or whenever you suspect a glandular lesion. That is the only indication at the moment for golden knife conization. Hysterectomy is mentioned only to be condemned, unless in very, 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 very specific rare situations where a gynecologist has to make a more radical decision. I would say surgery, radical surgery, hysterectomy is sharpening a pencil with an axe. That is the policy that we have. So this is the policy WHO also recommends throughout the world.
Ma'am, unmute.
At follow-up, 50% cases where it was positive, CIN3 was as it is even after the treatment. So that is why it was recommended that, you should not be doing a conservative treatment. But if you say that, thermal ablation is good enough, as in CIN1 and CIN2, in CIN3 also, because my experience is very, very limited, is where the patient does not want hysterectomy. We have done a thermal ablation and the patient are coming for follow-up, and none of the patients have become cancer.
Yeah, in fact, madam, when you read literature, things can vary because depending upon the series from where the data are quoted and the quality of the interventions and things like that. In controlled settings, actually, we have shown at least once that is sufficient. But our general policy is even if they don't come for follow-up, it is okay. Many of them will be cured. In inverted commas. And we have used HPV testing as a routine, as a test of cure, in addition to colposcopy and biopsies and some of the very rigorous evaluations. And we find very few, less than 5% of the patients with CIN3 have ever a recurrence. Okay. So from a practical point of view, in your private practice, it is very different, okay? Because you have a client and your relationship is very different, where you will get them for follow-up after 1 year, 2 years, and then repeatedly see. But in a public health practice, or in routine public health practice, I think just treat them. Put the emphasis on that. If they come for one follow-up at least after 24 months, that is excellent. If they don't come back, forget about them. This is what we say.
Good.
Thank you, sir, and thank you. It was a really great learning session, very simple thing, and we have the complexity of simplicity. We recognize presence of Dr. Lakneer Dhaliwal, Dr. Sangeeta Gupta among us, and if Dr. Lakneer Dhaliwal and Dr. Sangeeta wish to have their comment, good evening, ma'am. It is great to have you, and it was wonderful to have you in the all the discussion, and we will like to have your message for making our country cancer service free. And Dr. Sangeeta, Dr. Lakneer, ma'am, your words.
I have learnt a lot today from today's discussion. It was very nice. Many things have been made clear, especially Dr. Arora telling it the vaccination has to be deltoid. All of us have to be sensitized about this. We have to even go and check where sister is giving. When we order, if sister is giving vaccination, we must check it physically where she is giving it. So that part is very important. And number two, yes, for HPV vaccination, good discussion. We all have learned 1 dose, 2 dose. Yes, it will all depend further when it comes in the vaccination program, how it comes 1 dose, 2 dose. Like in private sector, catering to just few will not make difference overall for cancer service in India. And then it is our duty, whenever patient comes with anything, when we take their obstetrical history, parity, at the same time we should tell. We always say how many children, the last childbirth, when was it? At the same time we should tell that woman about vaccination of her boy or daughter, that this is very important. That we should take it as our duty. And then, of course, the young girls coming with the menstrual problem, hirsutism, PCOS, we must talk of this vaccination to them. So the awareness, we all are to be blamed for that. Whether people say we don't know about this vaccination, we are to be blamed. We have to make the public aware. All of us, whenever patient comes for any problem, we should talk of this and sensitize them. Like vaccination, very good. Screening with the LBC, pap smear, VIA, and very good. And Dr. Sharda says VIA, very good. I would come down further that at least we should do speculum examination, which sadly now most of the obstetricians, gynecologists, with the high technology available, getting away from simple speculum examination. Even that can tell us a lot. Patient comes with ultrasound report, the patient comes with the MRI showing a fibroid or some ovarian cyst or ovarian. Straightway patient is operated, hysterectomy done, histopathology report will come as CA cervix. That is so unfortunate and so sad. Patient will not even be getting a full radiotherapy now. So at least speculum examination is must from our side, all of us. I have learned a lot today. It was very nice.
So another thing which I have learned it from pediatrician is this vaccine must be given by the gynecologist herself, never by the sister.
Yes, very good.
And it is always deltoid. This pediatricians have told us, madam, ye vaccine wali jo baat hai, ye aapko khud deni. We don't give it, we don't allow the sisters to.
And patient buys from somewhere, not to give it. It has to be.
Yes, waiting them for 5 minutes also we have learned from them.
Yes, very good. And Dr. Shankar, of course, we always learn from him.
Yes. I think your presence made, it clarified everything.
Thank you, Dr. Shankar, and we look forward to great association.
Now taking a little bit forward, Dr. Ragini. Now, if the stamp has to be done after this particular panel discussion, clarity is there. Clarity is there among the top bosses of the North India Gynecologist Forum, stamped by Dr. Shankar Narayan and Dr. Neerja. I think one has to see to it, but unless it comes in black and white as a guideline from this thing, whether it is an IGF, whether it has to be extended to FOXIA and IAP together, it should come in black and white. So at least confusion goes away here.
Dr. Ragini, please unmute yourself.
So a white paper should come from an IGF and it should be circulated to all major association. And whatever we have learned, it should be in a small points to be sent to all. And what I have in end, I can say that it is very true that what Dr. Butler has said, until unless GOI say go ahead, we cannot at ourselves can say that you need one dose, but we can always talk to the patient. Look, this is under all those 4 state government is giving a one dose, and specifically the people who are unfortunate, they cannot have 2 doses, at least they can be given with the 1 dose. And I totally agree with the point. I have long back stopped giving vaccination by my staff nurse. I give by myself, and the whole cold chain is maintained, and the deltoid muscle, we all have been taught to give in the gluteal, and it is just a wastage of the vaccine. I think these 3 things also should be circulated with the window of opportunity, as Dr. Dhaliwal has said. I myself, in all cases, I said, my patient, do you have a pap smear? No. Why not? It is mandatory for you. Just like you have taken the COVID vaccine, you have to take the pap smear. Maybe my patients are affording, but unless we should stress on it, and we are clear in our mind that is, it is as mandatory as treating anything. We cannot percolate this to the people.
Actually, vaccination के लिए एक ना uniform, it is for everything. It is be it a TET-vac, be it a TD-vac, be it is a Boostrix. It is a uniform recommendation that be it is a NTD, all vaccination to be given in deltoid. So it is not only for this HPV. So when every sister and every nursing staff knows that it is to be given in deltoid, and so that makes something very practical, and almost it is inculcated into the practice. So of course we are looking forward to having a white paper statement. And second thing, in our country, the state health is a state rule, like it is not a central thing, which is a state government which follows, and at every level, at all 7 states and the union territories, we can create leaders who can talk to the politician along with the IAP and the other associations, so that we have to work together at every front so that it is inculcated, it is included into the national immunization schedule. That is the way, and that will actually clear many roadblocks. So thank you once again for wonderful discussion, and it could not have been the better celebration of Independence Day. Thanks to Dr. Ragini, thanks to Dr. Jyoti, and Mala, as a Secretary General, you owe to give the vote of thanks.
I think before that, we should have final word from Dr. Shankar Narayan. How should we go about?
Madam, we discussed a lot. Thank you, madam. And we said, to create awareness and vaccinate wherever possible, and create awareness wherever possible. And we have to use a lot of unconventional methods of increasing awareness. And so these are some of the areas we need to focus, and we need to also emphasize the vaccine is absolutely safe. It is as safe as, or even more safer than a tetanus toxoid, which we will not hesitate to inject at any place. Thank you. And
So
thank
one
you,
last question. So one last question. If we give single dose in private practice, is there any medical legal implication? Suppose patient comes with some problem later and we have given just 1 dose. Is there any giving 1 dose when it has not been approved?
Yeah.
डॉक्टर साहब, मैं थोड़ा सा मेडिको लीगल एक्सपर्ट की तरह बोलती हूँ कि आपको ये चीज काउंसलिंग में डालनी पड़ेगी. हाउ यू काउंसल, आप उसमें जहां पर लिखा है कि ये 1 डोज दिया गया, उसमें लिखेगा we will come back to you at 3 years time whether you have to take a booster.
Okay.
And ये जो 2 पेपर्स हैं, ये आपके जो WHO वाले पेपर हैं, अपने ड्रॉअर में रखने पड़ेंगे राइट हैंड साइड. Sir, what you have to say?
Yeah. I don't think there's you are right, madam. When you said the counsel and make the patient understand, and then in your private practice, you give a lot of importance to patient's view also. So you tell them, and then you advise them, and then depending upon their decision. I don't think there is a medical legal issue there. And actually, if you see in particularly in oncology practice, no licensing authority says this is the dose which has to be administered. So quite often we administer the dose according to the general condition, the NADR and CBC and all those things. But you can say, oh, they are patients. They are patients with disease where you have freedom. These are healthy people. So with all the evidence that we have, we can counsel them, and then we can go ahead, because that is what is being done in many places. In India, a lot of places where a single dose is being practiced by gynecologists. And then again, if you are more careful, if you want to be more careful, you can even write a consent form. A simple consent form where this has been explained. So I understand this is safe and this is effective as far as the scientific data are concerned. So I agree for that. That is very simple.
I don't think, Dr. Ajay, a vaccination failure is never a medico-legal issue. Be it whatever vaccine it is, vaccine failure can
true.
never be medico-legal. It is neither we are manufacturing, it is always 80 to 95 to 99%. So we don't think, Shweta, that it will come as a medico-legal issue. Vaccination failure.
Shweta has not asked the failure of the vaccine. Shweta has asked the single dose. If she does not give the second dose at that time, not in the
The answer for that is, if you write a white paper, you put it in a waiting area, and sir has said that you take a consent. So I think as we take it for outdoor procedure consent, we take a consent for a vaccination and we make a booklet separately, and keep it for 3 years.
Madam, that is also a failure of the vaccine. If you look at the scientific data, when you compare effectiveness in terms of prevention of CAN2 and 3, which are real precancerous lesions, they are similar. So the breakthrough infections and breakthrough disease is extremely rare with any of these doses. So one cannot say, 3 doses far superior to a single dose in preventing breakthrough infections or in preventing CAN2 to 3. So most of the evidence which is coming at 10 to 15 years following a single dose or 2 dose, 3 doses, now based on disease, based on CAN3. Actually, now CAN3 evidence is very strong, actually. Even in the Indian trial, where we have already started screening from the age of 25 years, if you see the incidence of CAN3 or CAN2 disease in 3 doses, 2 doses, and single dose is 0, as opposed to a good proportion in the control group. A default control group is there, which the government permitted to recruit later to compare actually the single dose with that. So there is no evidence so far, that a higher failure rate with a single dose vaccine. So Sadhana Madam is absolutely right. The vaccine failure, is realized, because even the most effective vaccines have a certain proportion of failure rate and breakthrough infections depart because of various things we don't understand. So that should not be an issue. So I don't think it will be an issue. But if you are wanted to be more cautious, then even you can get an informed consent sign.
Sir, I'm especially thankful to you that I'm going wiser on hysterectomy front on CAN3.
No, madam, you all make us more wiser. And Dr. Sweta's question was absolutely brilliant. Is there a medical legal issue? I never thought about that until this time. We learned a lot from Dr. Ajay. It's a very interesting propositions he made from a pediatrician's viewpoint.
Sir, he forced us to that, we must have a joint deliberation. So I gave a responsibility to Dr. Ragini, that, this particular thing must be done when you call the experts. So we hear from the horse's mouth what is the truth.
Thank you, Mala. So we are well in time. So Mala, please go ahead.
Thank you, Mala. Thank you.
It's my pleasure and privilege to propose a vote of thanks. First of all, I thank Dr. Sharda Madam for raising this webinar to hear from the horse's mouth what is the exact position of the HPV vaccination and how should we go about it. And I thank Dr. Ragini Madam, who is the President-elect for NIGF, and Dr. Jyoti Malik, who has been the convener of this program. I thank Dr. Sadhana Gupta Madam, who has been the moderator of this wonderful session. And I thank all the experts, Dr. Sharda Jain, Dr. Nija Batla Madam, Dr. Shweta Balani, Dr. Shankar Narayan Sir, and Dr. Ajay Arora, who had given such interactive session, and so much of inputs have come and so much points have been raised and so many points have been clarified. I thank Dr. Lagbir Dhaliwal Madam, who despite of her busy schedule, she had joined us and given her inputs for our insights. I must thank Dr. Narendra Malhotra, who despite his busy schedule sent his message for this particular webinar. I thank all the delegates who have joined in for this webinar and got a good message about how to go about the HPV vaccination, what are the doses, and how can we remove all the clarification from the vaccination point of view. And in the end, I thank Lynette for giving us this platform. Thank you, everyone. Goodbye and good night, and happy Independence Day to each and every one of you.
Thank you, ma'am.
Thank you so much.
Please join North India Gynae Forum. We have clicked this www.nigf.in. Please join in large number. All OB Gynae, all postgraduates. Thank you. Happy.
But I think this has been the biggest gift of this 15th August. Biggest gift.
Thank you.
Thank you so much.
Thank you.
Thank you, everyone. Happy Independence Day to you all. Thank you.
Discussion about 1 dose or 2 dose or 3. So that's good. So in this of certified NIGF, there will be no discussions of single dose or double dose. So that's done.
Thank you. Thank you. So,
Thank you, ma'am.
I think counseling is very important, madam.
Thank you, ma'am.
People, you can
Yes,
end
Sneha,
the meeting.
officially you can close it.
You can end the meeting.
Thank you.
Over to you, Sneha.
Thank you so much, everyone, for this wonderful session. Thank you, and happy Independence to you all. So, with all of your permission, can we sign out here?
Yeah, please.
Thank you so much. Thank you.